Just to lead off the questioning, let me start off with a question to Admiral Zimmer. You mentioned about 1/3 of the NGOs that are getting assistance happen to be faith-based. One of the concerns that I've expressed from the very beginning, both with PEPFAR and Malaria and every other U.S. foreign aid program, especially as it relates to Africa, has been the early exclusion of faith-based organizations, primarily because of ideological reasons. But there appears to be, and I think there's been good, strong support for this. I actually wrote the conscience clause for the PEPFAR program because of that exclusion. And if you could just elaborate a bit on how, especially indigenous faith-based groups are being included. If we want to end the pandemic of HIV/AIDS, it seems to me, TB, the problems associated there, and of course, the malaria problem, we need to have as partners those faith-based groups. If you could touch on that.
Yeah, thanks for the question. When PMI was launched, one of the first things we did was to look at the best practices of PEPFAR and modeled some of our programmatics after the PEPFAR model. So to the extent that there were clear guidances coming from here and from the administration, we looked at them and embraced them. But I can tell you from the beginning of PMI, we intentionally looked at a deliberate engagement of the NGOs in the field, specifically looked at the merits of the faith-based organizations because we acknowledged, and from personal experience, accepted the fact that they were there before we got there, and they'll be there after we go. And when we start embracing capacity building and sustainability of programs, the local NGOs, specifically the faith-based, are a huge component of building for the future.
Appreciate that. You know, the impact on childhood cognitive development, we know that obviously our goal is to eradicate malaria and to prevent deaths, but also to mitigate morbidity and other consequences like the impact on cognitive development. What happened? Is the timeliness of the intervention key? We know that with, I chair the Lyme Disease Caucus here in the House and have a bill pending that I hope will get up on establishing a Blue Ribbon Commission on Lyme disease, particularly chronic Lyme. And the longer the parasite grows inside an individual, the worse its deleterious effects. And I'm wondering, the issue of how this malaffects children as they become adolescents, adults, and right on through the rest of their life.
You're asking a rather technical question, and I would defer that to some of our scientists and colleagues when it comes to the impact or delayed, the impact of delayed parasite clearance from a system. I do know that we have a very rigorous prenatal program so that when pregnant women go into the clinics, we're providing preventative treatment. So in terms of the health of the newborn child, it's being addressed through that prevention measure. But when a child presents with a fever, we're committed to appropriate diagnosis and then treatment. So at an early age, if the child presents and is diagnosed with a fever, we do everything we can to provide treatment.
In his testimony, Ambassador Dybel, the Executive Director of the Global Fund, points out that between 2004 and 2010, and the coverage need, the level of need was essentially met, but only 92 million nets were delivered by manufacturers in 2011, largely due to funding constraints, and in 2012, only 66 million nets were produced. He points out that in February of this year, the Global Fund and WHO and other partners, and I'm sure that includes you and us, the United States, estimated that 77 million nets were needed to maintain coverage for communities that the Global Fund has previously protected. He also talks about, the big push to replace insecticide-treated nets in its new and interim funding grant streams, along with bolstering diagnostic and treatment needs. And bottom line, that between 2013 and 2015, there's a $3.5 billion gap. Now, I know the United States has been generous. It has been the leader. Is there more that we could be doing? I mean, can we be partners, Congress, in ensuring that that gap is closed?
The fact that we know what the gap is and we can have these numbers represents information that we didn't have 5 years ago. Right. So as we look at supporting the country's requirements, we're able to refine the net requirements and then collectively discuss at the funding level, the partner level, and at the national level how best to direct those resources. I think it's important to acknowledge that since 2008 and 9, our partners, along with the United States, have distributed over 300 million bed nets to sub-Saharan Africa, which represents coverage to close to 600 million people. I think the figure is 578 million. So we are making tremendous progress. As we look at those at risk, I think it's important to look at the full toolkit that we have. 4 of the interventions that we use are focused on prevention. Bed nets, of course, is one, along with indoor residual spraying. We are looking at country requirements, the most at-risk population groups, and moving forward with the funding that we have. So are there gaps? You bet. Are we dealing with them better? Yes. We just have to keep at it.
And if you could help us, I mean, we want to be advocates. I certainly personally want to make sure that all that can be done is done. I thought that, again, Ambassador Dybel makes an excellent point. Progress made or lose momentum. The reality is invest now or pay forever, which is a very strong and I think very declarative statement that we could make a difference, but funding is key, and obviously deploying those resources prudently is key. Colonel, if I could just ask you, your written testimony goes into some great length. Thank you for your oral testimony as well. You point out that the Walter Reed Army Institute for Research, along with a pharmaceutical company, has developed and is what is currently the world's leading malaria vaccine candidate. You point out that the product is currently in phase 3 clinical trials in Africa. If you maybe would touch on where in Africa. Is it Kenya, where we have the lab and the medical research collaboration? And how close are we to actually developing a vaccine that is deployable?
Yes, Chairman Smith, the question of partnering with a drug company, we do partner with all of the time with some sort of commercial entity to make sure that our products go forward. None of the products that we actually produce are things that are necessarily borne strictly by the United States to move forward. The question of where this work is being done, it's the phase 3 trial is principally being done in Kenya right now, where we have our laboratory. This work is moved forward significantly, but of course the question of when are we going to have a vaccine is really tied up in some very significant details. First of all, the vaccine that we have right now is not a vaccine that absolutely protects an individual from getting malaria. The great thing about this vaccine, and this is why it's being pursued principally in Africa, is because of the fact that it reduces the mortality associated with the disease. This vaccine, just like a lot of other vaccines that we're having difficulties with, such as HIV, are things in which they don't naturally occur in nature. We don't have a situation like we have, for example, with chickenpox, in which maybe somebody gets chickenpox and then they aren't going to get chickenpox again. Those vaccines are the easy ones. Those are the ones that have already been developed. What we're trying to do is actually develop a vaccine for a condition that doesn't occur in nature, so it's a lot tougher to do. What we have been able to mimic is the fact that children that have repeatedly gotten malaria are at lower risk of dying from malaria than individuals that may get it the first time. And this is a real success. It helps reduce the mortality. and it produces some information for us in possibly moving forward into a vaccine that does have significantly more efficacy and something that may actually prevent somebody from getting infected.
Let me ask you, Colonel, if I could, you point out that funding for malaria research and development in the military has been suffering since Vietnam. You talk about how you have worked very creatively, partnering with others to try to lessen the impact of that diminished funding, and I think $10 million is what you have in use for research. You also point out that resistance is a fact of drug development, and even the most cautious of drugs, with the organisms we are fighting, will always find a way to defeat our treatments, which is a very ominous statement and a very disconcerting statement. And we know in some 4 countries in Southeast Asia, and Dr. Frieden was very emphatic on that when he appeared before our committee just a few weeks ago, there's concerns about drug resistance to artemisinin. Could you speak to that issue of drug resistance and also that budget for research? What would more money enable you to do if it were to be available above the $10 million?
Yes, sir. The issue of resistance is something that we deal with not just for malaria, but for a lot of diseases. The malarial parasite is a very ingenious organism that is actually, I guess, just trying to survive. And we're constantly trying to beat it down. It has found a way of practically defeating every single drug that we have produced, all the way back to something that we've been using like quinine for over 300 years. All of the new drugs that are out there, mefloquine, Fansidar, all of these types of drugs, Malarone even, there is resistance. And our biggest tool in our arsenal right now are the artemisinin-based drugs. We are seeing an increase in the potential for resistance in Southeast Asia, particularly along the Thai-Cambodian border, where we've seen a lot of resistance arise. And we are going to, every single time we produce a new drug, these organisms are going to find a way around it, and that's why we need to have continued vigilance. That's why every single anti-malarial that has basically come out since World War II has had the involvement of the Walter Reed Army Institute of Research, because of the fact that we have continually worked on it virtually our entire existence, looking at a new drug. So every time we have a new one that's out there, we don't stop and celebrate that we have the new one. We're actually looking for yet the next one that's out there, and we have a full pipeline of drugs that are being developed and looking for yet that next generation, because we know we are going to have resistance, and there is no way of actually stopping that from moving forward. As far as the budget, I think everybody would just love to have more money. There are limited resources that are going to be available. I think what we would like to have, more so than anything else, is just to continue to get the money that we have been palmed. And that allows us to do the planning that's really necessary to move forward with our partnerships, because our people are very entrepreneurial. And whatever investment that the U.S. taxpayer puts into developing these drugs, we are able to partner with private organizations, with academia, with other government organizations, and really move the goal forward by bringing those types of partnerships together in this ecosystem that increases every single dollar 3, 4, 5 times and increase our budget to move things forward.
Would be concerned, not just, obviously we're our brothers and sisters keeper, and that's what this program is built on, but there is the possibility, as you pointed out, of malaria being reintroduced into the United States. And I thought, there's something I never read in the history books when we talked about the Civil War. You point out in the 1860s, the Civil War saw 50% of the Caucasian troops and a staggering 80% of the black troops contracting malaria annually. That is extraordinary, and that's information that I think just underscores we had it here, it's gone. Now we have to hope and pray and work hard that it will soon be eradicated in Africa and everywhere else that it is. Mr. Burr.